In January 2015, the American Society of Nephrology created the ASN Nephrology Match Task Force to evaluate the match for nephrology fellows and make recommendations for improving the process. The task force was composed of key stakeholders in the kidney space, including ASN counselors, nephrology training program directors, division chiefs, and ASN workforce committee members. In this first episode of a two-part ASN Kidney News podcast series on the nephrology match, ASN Executive Director Todd Ibrahim speaks with Task Force Chair and ASN President-elect Dr. Ray Harris and Task Force member Dr. Matthew Sparks about the recommendations approved by ASN Council, including the new all-in policy.
Dr. Harris, why did ASN create a nephrology match task force?
Well, as everybody knows, after the last match, there was a real concern in the community, both about the results of the match in the sense that so many programs didn't fill and that there was a paucity of number of applicants. In addition, there was a lot of sort of general concern and angst around the country about whether the spirit of the match was being followed by all programs, in the sense that whether some programs were acting outside of the match to recruit fellows, and really a sort of a crisis of confidence about whether the match was going to continue. And so for that reason, the ASN decided to create the task force to make recommendations about whether nephrology should continue to participate in the match, and if so, how would that look?
So, Dr. Sparks, why did you agree to serve on the task force?
To me, it was important crossroads for the nephrology community to really tackle this issue so that applicants would feel like they had the time to look at every program, and every program also had a chance to look at a lot of different fellows. So to me, this is an issue that I was really interested in, and also had some personal issues with how the match had been in my own life. So I wanted to take part in this task force for those reasons.
So, Dr. Harris, how did the task force attempt to fulfill its charge?
The task force was given really 4 charges to look at. One is basically, should nephrology continue to participate in the match program, which is generated and carried out by the National Residents Match Program, NRMP, which I may mention in the future. So NRMP is what that stands for. If we did decide to continue, what should we decide about how the match would exist? Should it be an all-in participation or continue to be voluntary as it currently stands? The third recommendation was to provide some recommendation to the Council regarding the use of tracks within the nephrology match program. And then fourth, develop or identify resources that will help institutions to consider and assess the appropriate number of slots for their programs. So to do this, we've had weekly phone calls every Monday at 10 a.m. Central Standard Time, and with great participation. During those conference calls, we've wrestled with these 4 recommendations. In addition, we sent out surveys to both the training program directors and the current fellows concerning their perceptions about the match. And we also talked with, which was very helpful, with Deborah Proctor, who is a professor of medicine and gastroenterology at Yale, who really was instrumental in resuscitating GI's match. In the early 2000s, GI's match had really fallen apart, and there was really a sense of chaos among it's not a sense, there was actual chaos in the whole fellowship application process, and it was very interesting for us to hear why GI went back into the match and how they initiated that. So we've had a very fruitful 6 weeks or so of meetings.
So during these 6 weeks of deliberations, Dr. Sparks, what surprised you the most about the discussions?
I don't know if I was really surprised, but I think what really came out was a very good unified voice that each of the participants of the committee spoke with. And not only that, it was very refreshing to see how devoted each of the members was to not only to the future of the field, but also the future nephrologists, the applicants that were interested in nephrology. I think that we always came back to that issue during each of these deliberations.
And you're still relatively close to your fellowship training. I'm just wondering, from your perspective personally, what were some of the reasons that nephrology was so appealing to you as a career choice?
Right. I finished my fellowship about 4 years ago, and the most appealing things to me, one, when I rounded during my residency, I noticed that all of the nephrologists who were my mentors were the go-to people for patients that had significant problems. They never shied away from the sickest patients, and they made a lot of changes in the course of the patient's trajectory while they're in the hospital. So to me, I felt like nephrologists were the doctors of the hospital, and I wanted to be like that. The other thing that interested me was I felt like I could make a big difference in research. There was a lot of room to be made in the field, and I wanted to be a part of that.
So, Dr. Harris, I know that the task force has made 2 recommendations and is still working on, the remaining 2 aspects of its charge. Do you mind just describing sort of what the 2 recommendations the task force has reached consensus on?
The 2 recommendations were, one, that nephrology should continue in the NRMP match, and secondly, which was, we abdicated that there would be an all-in policy. These were unanimous decisions by the task force, enthusiastically unanimous decisions.
So just to repeat those, so the 2 recommendations, which are the sort of 2 first parts of the charge, was that first, nephrology should stay in the NRMP, that there should continue to be a match for nephrology fellows the way there are for all internal medicine fellows and all residents, so that there's a nice sort of, it's seamless from medical school to residency to nephrology fellowship. The second recommendation is that there should be a all-in policy to govern the match. And I guess just to sort of take the all-in policy, because I think that may not be as clear to our listeners, Dr. Sparks, could you just sort of describe what an all-in policy would mean for an internal medicine resident who's considering a fellowship in adult nephrology?
In an all-in policy, internal medicine residents who are interested in pursuing a career in nephrology can be assured that all spots will be listed in the match and that programs will not offer spots outside of the match, or the so-called pre-match. Even if they're interested in a research track, they should feel free to interview and contemplate any programs they are interested in.
Dr. Harris, anything to add in terms of the experience for an internal medicine resident as a result of both nephrology staying in the match but also the all-in policy?
Yeah, 2 things. One, of course, that by participating in the match, all residents will first have to participate in the ERAS program in order to list for the match. But the second is that, as Matthew said, not only will they be able to look at all programs, but the second is that they won't no longer be any undue pressure, if you might say, to go outside of the match or to not participate in the match, and therefore to be locked into a program before they had the chance to really explore all options.
And while I understand the benefit from the perspective of the resident who's transitioning into being a fellow, Dr. Harris, I'm a little confused as to what the advantage is for the nephrology fellowship training program. So do you mind explaining why the task force made the decision that the all-in policy would also be beneficial for training programs?
I think for the benefit is that it's a level playing field. There was really a crisis of confidence going on among training programs, with the sense that programs felt like certain programs were poaching fellows, forcing them to make decisions before the match day and go outside of the match, or basically just not following either the spirit or actually the rules of the match. And so we felt like, as a task force, the only way for the match to work effectively so that there would not be this poisoning of well, if you will, was to have all applicants be participating and all programs be participating. And with an all-in, it's really all fellow slots have to be listed. So I think with this, it will be a level playing field. And if there are applicants who have already made a decision to stay at an institution, they will still enter the match, but will only list their program as top, and the program can enter them as their top choice, and the computer will automatically match them anyway. So there's no loss for those applicants who want to stay at a program or have already decided to go to a specific program. But this way there won't be any opportunity for going outside of the match or bending the rules, if you will.
Dr. Harris, you mentioned that Dr. Proctor from Yale really was helpful in terms of the experience in gastroenterology in the period that they did not have a match and some of the challenges they had. Do you mind just summarizing what some of those challenges were?
Well, I think it's exactly what we were worried about that was going to happen with the nephrology match, is that there was a sense that each program felt other programs were gaming the system or cheating or trying to take advantage by compelling applicants to sign. And what happened was that this quickly became well recognized by applicants, and so during that time, the number of applications for GI fellowship dropped dramatically, and also it was felt like the quality of the applicants dropped dramatically. And this was attributed in large part to the sense that residents had applying that they didn't have an equal opportunity to make decisions, and so they felt like it was really a major detriment to their whole training programs nationwide. And so that was why they undertook this really concerted effort to reinitiate a match. Luckily, nephrology has not gotten to that point yet because we have not lost our match, but it was an eye-opening experience to hear what they had gone through during that period.
So, Dr. Sparks, I know one of the outcomes of the task force is the goal to publish a formal resolution that supports these policy changes, both sort of reaffirming support for the fellowship match through the NRMP and then adopting the all-in policy. Why did the task force decide that publishing a formal resolution was so important?
I think this also came from some of the experience that gastroenterology faced, and that really what drove success for reinitiating the match was getting wide participation from programs. The other thing, we believe that it was very important to draft a formal resolution to remind all programs and potential applicants that the integrity of the nephrology fellowship match is vital, not only to ensure a robust pool of applicants, but also to ensure a strong future for our specialty. We thought that a strong match will help create an environment that is win-win for both the applicant and the program.
Dr. Sparks, Dr. Harris, thank you for joining us for today's discussion.
Thank you.
Thank you.
In the next episode of this two-part series on the nephrology match, ASN will speak with National Resident Matching Program President and CEO, Ms. Mona Signer, about regulation of the new all-in policy and other requirements. This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast in the American Society of Nephrology.